So even though there was a large there was a significant proportion of patients on the study who were either stage 2 or node negative, the vast majority of patients did still receive chemotherapy. So about 88% of patients on the study received chemotherapy. And for all patients who received chemotherapy, there was still a consistent benefit of receiving the drug. So whether or not they were stage 2 or stage 3, node positive, node negative, they did derive benefit from the drug in the chemotherapy arm. There was a consistent signal or trend towards benefit in the no chemotherapy arm, but of course, if patients who have stage 2 or stage 3 disease are not being recommended for chemotherapy by their oncologist from a standard of care perspective, they do likely have a lower biology or lower risk biology disease, and we would not expect to see many patients like that have a recurrence within a 3-year time frame, since this was based on 3-year invasive disease-free survival. So while we didn't see a striking benefit in the no chemotherapy arm, I don't think that means that we can use that to say that if patients did not need chemotherapy, there's no benefit from ribociclib, as I think it's far too early to tell that, because those lower risk biology tumors do tend to recur, further down the line. So I think we need to pay attention to how the data unfolds as time goes on. From an endocrine therapy perspective, I think the most reassuring thing that we saw from this analysis is that patients who had received up to 1 year of endocrine therapy didn't do any worse than patients who had started on endocrine therapy maybe just before enrollment. So patients who had been receiving over 26 weeks of endocrine therapy, the hazard ratio for invasive disease-free survival was identical to that seen in the patients who had only just started it before enrollment in the study. How I think this impacts people clinically is that for doctors who want to take their time getting patients started on endocrine therapy, maybe in a premenopausal patient who might have a lot of side effects from endocrine therapy, starting slowly with tamoxifen, adding on the ovarian function suppression with goserelin or leuprolide, and then adding in the aromatase inhibitor, taking that stepwise approach, which many people like to do to sort of ease patients into endocrine therapy. I think this data supports the fact and provides reassurance that you can take that time to get started before needing to, add in the CDK4/6 inhibitor, and that does not impact efficacy at all.